I welcome you all to today's session of Pediatric Anesthesia NEET MCQ, Super Specialty MCQs. I'm Dr. Priyanka Karnik. I'm the consultant pediatric anesthesiologist at MRR Children's Hospital. And today we will be studying some pediatric anesthesia related MCQs. So let us begin. So first is a 3-month-old infant with Pierre-Robin sequence who is undergoing induction for cleft palate repair under general anesthesia. During the process, the anesthesiologist encounters significant difficulty in achieving bag mask ventilation due to the infant's micrognathia and posteriorly displaced tongue, that is glossoptosis. The oxygen saturation begins to drop. So what is the next most appropriate step to establish effective ventilation? So let us see the all the options. So first is attempt direct laryngoscopy and endotracheal intubation. Second is insert a supraglottic airway. C is perform an emergency tracheostomy, and D is insert a nasopharyngeal airway and continue bag mask ventilation. So the most appropriate answer is insert a nasopharyngeal airway and continue bag mask ventilation. Now, why is it so? So here our most important aim is to establish effective ventilation. So prevent hypoxia and we have to establish oxygenation. Our goal is not to intubate the patient but to maintain the saturation of the patient and maintain adequate ventilation. So the most appropriate step would be to insert a nasopharyngeal or an oropharyngeal airway and continue bag mask ventilation so as to avoid hypoxia. Now let us look at the other options. So how we can rule them. Now first option is to attempt direct laryngoscopy and endotracheal intubation. Now as we all know, this is easier said than done because it is Pierre-Robin sequence. So it consists of micrognathia, retrognathia, glossoptosis, and sometimes even cleft palate. So it is going to be a very difficult intubation, and hence to try to attempt direct laryngoscopy and endotracheal intubation would be just wasting time and letting the saturation drop further. Then inserting a supraglottic airway. Again, with retrognathia and with glossoptosis, it will be difficult to insert a supraglottic airway. And first, we should try to go with the least invasive way possible. So here we would first insert a nasopharyngeal airway, and if with that we cannot establish a proper airway, then we would go for a supraglottic airway device. After that, the next option is perform an emergency tracheostomy. Now, tracheostomy is again a cannot intubate, cannot oxygenate situation, which is a last step. So, when we cannot establish airway, even with your nasopharyngeal airway or LMA or intubation, then we would go for a tracheostomy. So, our logical answer is insert a nasopharyngeal airway and continue bag mask ventilation. Let us see the next one. So a 2-year-old child is undergoing exploratory laparotomy, that is exploratory abdominal surgery under general anesthesia. Midway through the procedure, the anesthesiologist notes a heart rate of 180 per minute, blood pressure of 75/40, and markedly decreased urine output. The child has received lactated ringer solution for intraoperative maintenance. What is the most appropriate next step in management? So the options are administer up to 20 ml per kg of isotonic crystalloid, start furosemide to induce diuresis, administer 5% albumin, and last is transfuse packed red blood cells. So here the correct answer is administer 20 ml per kg of isotonic crystalloid. Now why is it so? So the patient is undergoing abdominal surgery and the child has been receiving an intraoperative maintenance of lactated ringer solution. Now here we are seeing that the heart rate is 180, that there is tachycardia, there is hypotension, and there is decreased urine output. So all of this points towards hypovolemia. And we all know that in children undergoing abdominal surgery, just maintenance of fluids is not going to suffice. We have to replace the ongoing losses, that is the third space losses, as well as whatever, because of the bowel exposed, whatever is happening, whatever loss is happening has to be replaced. So the replacement fluid always has to be an isotonic fluid, either ringer lactate or normal saline. So any isotonic crystalloid bolus has to be given, and the bolus can be 20 ml per kg, up to 20 ml per kg. Sometimes even further boluses will be required. So now let us see at the other options. So start furosemide to induce diuresis. Now, if you give Lasix, you will be further causing hypovolemia because of increased urine output, and you will be only taking part of one aspect, that is decreased urine output. But what about the tachycardia and hypotension? So for that, for the hypovolemia, you need to give fluids. Now, administering 5% albumin. Now, albumin is a colloid that can be used, but that is only given when you have given, say, 2 boluses of isotonic crystalloid, and even after that, the blood pressure is not getting maintained or the tachycardia is not settling. Then you may think of giving a colloid like albumin or FFP or even hetastarch. Next is transfused packed red blood cells. Now, RBCs are only given when there is significant blood loss or when the hemoglobin is goes to less than 8 milligram per, 8 gram per DL, or if there is significant, that is 10 ml per kg of blood loss that has happened, or the patient's hemoglobin is low to begin with. Then you have to replace whatever loss happens according as ml per ml with blood. So here the first logical step would be to give a bolus of 20 ml per kg of isotonic crystalloid. Now, next is a full-term neonate present shortly after birth with severe respiratory distress and scaphoid abdomen. Chest X-ray reveals bowel loops in the left hemithorax consistent with congenital diaphragmatic hernia, that is CDH. The baby is transferred immediately to the NICU for respiratory support. Which of the following is the most appropriate initial ventilatory management strategy? First is high pressure ventilation with 100% oxygen. Second is bag mask ventilation with intubation, before intubation, gentle ventilation with permissive hypercapnia, and the last is elective tracheostomy for prolonged ventilation. So here the correct answer is gentle ventilation with permissive hypercapnia. Okay, and gentle ventilation, that is after intubation we have to ventilate gently and give permissive hypercapnia. Now we know over here that the baby has CDH. So in CDH the bowel loops are in the thorax because there is a defect in the diaphragm. So here if you try to bag mask ventilate the patient, the bowel are further going to get dilated and they're going to further cause pressure on the lungs and respiratory insufficiency. So that is why now we will rule out all the other options. The first option is high pressure ventilation with 100% FiO2. Now, as I said, if you give a high pressure ventilation, the bowels will also get dilated, and also because of the lungs here are hypoplastic, if you give a high pressure ventilation then there can be barotrauma to the lungs. So giving high pressure ventilation with 100% FiO2 is definitely not the answer. Second is bag mask ventilation before intubation. Now, again, if you give bag mask ventilation, the air will not only go into the trachea, it will also go through the esophagus, into the abdomen, and into the bowel loops. So again, there will be distension of the bowel loops, and the lungs will be further compressed, and there will be hypoxia. So you will be doing damage rather than helping the patient. And the last option is elective tracheostomy for prolonged ventilation. Now, elective tracheostomy, again, you will not do in this situation because this is an emergency situation. So, elective tracheostomy will only be done if suppose the neonate post-operatively requires a prolonged ventilation. Only then we would go for a elective tracheostomy. So, here the most appropriate step would be to intubate the patient and give gentle ventilation, and we actually do not aim for a normal CO2 levels. So even up to 60 to 65 CO2 is also acceptable. So gentle ventilation with permissive hypercapnia. So lung protective ventilation strategies are important in CDH. Next is a 3-day-old neonate with known transposition of great arteries, that is TGA, is scheduled for an emergency arterial switch procedure due to worsening central cyanosis and poor oxygenation. Which of the following intraoperative anesthetic strategies is most appropriate to optimize oxygenation and hemodynamic stability? So here the options are low FiO2, high PEEP and permissive hypercapnia. Second is maintain high FiO2, avoid acidosis and optimize preload. C is aggressive diuresis and afterload reduction. And D is early extubation to reduce ventilator associated complications. So here the answer is maintain high FiO2, avoid acidosis and optimize preload. Now, what is transposition of great arteries? Transposition of great arteries is basically a complex cyanotic heart disease where the aorta arises from the right ventricle and the pulmonary arteries, they arise from the left ventricle. And these are two parallel circulations which do not actually mix with each other. So the deoxygenated blood will go into the aorta, and then again it will